It's a real honor to be back, and I'm really excited to be here. When I was asked to do OMT in the psychiatric population, and I actually do a lot of OMM. I work in a state hospital, and I do OMM every week, and usually only a few times a week, but compared to my counterparts, that's a lot. I believe I'm the only one in my hospital doing that. And I wanted to start out by talking about why I became a psychiatrist. This picture of me and my dad at White Coat's one of the last pictures I have with him. When I came here because I wanted to do OMM. I wanted to do family medicine, ER. I wanted to do manipulation. I just came here really excited about that. I couldn't imagine being any other kind of physician except for an osteopath. I lived in southern West Virginia for over 20 years, and all I knew was DOs, and all I know is that when my back hurt, they fixed it, and I went back to my job on the ambulance. And I didn't feel like I could be a complete physician if I didn't go to an osteopathic school. So then all of a sudden, I'm on my third year rotations, and you know, I love all my rotations. When you're on third year, hopefully you're gonna like everything like I did, but at the end of the day, I was always excited to go home. I was tired, I was ready to go home. And then all of a sudden on my psychiatric rotation, I was like, I don't care if I go home. I'll come in this weekend, I'll do this. And next thing I know, by the end of the month, here I am, this person ready to have all these audition rotations, these family med residencies, excited to go do all this, and I'm like, wow, I'm now changing my whole career. And one of the things a lot of people told me is, why are you hanging up the stethoscope? Are you going to stop using your hands? All these things. And the more I look at it, you know, psychiatry is really an osteopathic profession naturally. Before I start going more into this, I want to have a disclaimer that while I'm sitting here telling you that, you know, I use OMM in the psychiatric population, and when you start going out, be careful about when you do OMM. A lot of psychiatrists do not do OMM, and the reason for that isn't because they're scared of patients being violent or anything like that. You obviously aren't going to touch a patient that's agitated. But when you deal with severe mental illness, you're talking about patients who see the world in a different way. They have very delusional thoughts. They don't see things clearly. So it's really easy for them to misinterpret therapeutic touch. I would like to start off with the osteopathic tenets. And the reason for that is when I was making that debate about going into psychiatry, this is one of the things I looked at. And when we look at the first thing about the osteopathic tenets, is the body is a unit of the body, mind, and spirit. And a lot of times we can forget that. When we look, as a psychiatrist, I feel like I was very adequately trained above par compared to others, because I already go in looking at what is a patient's family home life like? What are their stressors that have led to this? And we really look at all of this. And you know, structure and function are related. When there's depression, we know what neurochemicals are deficient in those things. One of the things I'd like to go ahead and throw out there before we get started is, when you see patients with mental health disorders, bipolar or depression or schizophrenia, what kind of medical comorbidities, what kind of medical problems do you see in general that a lot of these patients have? Diabetes is one. Unfortunately, a lot of that is due to our medicines. How about outside of that? Smoking. Smoking is a huge one. Believe it or not, I actually use smoking as a vital sign, because especially with schizophrenic bipolar patients, they smoke more when they are not stable.
Substance abuse in general?
What's that?
Substance abuse in general.
Right. A lot of substance abuse, huge comorbidity there. Any other? All right. Well, I'm not going to talk so much about those that we talked about, a little bit about addictions today, but the ones in general that I find really complicate a lot of my patients with mood disorder are migraines, irritable bowel syndrome, and chronic pain. And the chronic pain has a lot to do with the addiction side. And before we talk about those things, I'm going to talk about one of your basic things, which is the monoamine hypothesis, which I'm going to try to pull in and show you the relevance between that and the others. All the images I took from today, most of them come from these books by Stephen Stahl. If you're interested in psychiatry and you're interested in medications in psychiatry, these are the best books to use to learn that, in my opinion. There are a lot of, as a matter of fact, whenever I'm prescribing the medicines, I'm seeing his drawings of them in my head as I'm doing it. So the next thing I'd like to ask is, what is psychosomatic? We talk about a lot of our reflexes, but what about psychosomatic specifically? Didn't know I was going to ask all these questions. I'm very much a participation person. No? Well, psychosomatic is that link between the psyche and the body. So a lot of times, psychiatrists will say a patient has a lot of somatic complaints. We'll see that they have a lot of stomach issues or a lot of stomach pain, a lot of headaches in general, and a lot of times their physical complaints are directly tied to their mood at the time. There's a great chapter in the family medicine book done by Nelson about mental illness and the link between that. When we talk about the monoamine hypothesis, it's 3 neurochemicals. And when we treat depression right now with our hypothesis, we are treating one of these 3 things. And the 3 main neurochemicals are dopamine, serotonin, and norepinephrine. And as we start going into some of these medical comorbidities, you're going to see the tie-in between these and those medical conditions. Basically, the way we feel about it is when we have depression, we have a decrease in these monoamines. And when we treat depression and mental illness, we find that these neurochemicals are related to certain things. Norepinephrine, alertness, concentration, forming new memories. One of the ADHD medications out there, it's Strattera, which is norepinephrine. Serotonin, that is a lot of our anxiety, a lot of our obsessions and compulsions and depression. And then dopamine is attention, pleasure, reward, and motivation. When we look at it in a different way with where mood stands and where neurochemicals in a normal mood and a normal balance of mood, all 3 are pretty even. When you have a lot of problems like loss of happiness, when you have the atypical depression with a lot of sleeping all the time and eating too much, that is more of a problem with dopamine and some norepinephrine. And then when you talk about that irritability, like I call it like the angry man syndrome, where men express their depression as anger, we go more towards the serotonin route. Anxiety is very serotonin based. And then in general, pharmacologically, we treat these as our first line, especially as primary care providers. First line being, our SSRIs, serotonin, norepinephrine reuptake inhibitors like venlafaxine and duloxetine when they have a lot of pain issues that go along with their mood. And then sometimes we'll use medications like bupropion or Wellbutrin when serotonin isn't the problem and we're looking at focusing more on dopamine and norepinephrine. So I know this is like, your 5-minute introduction to depression and treatment of that, but I just wanted a quick overview of that before we start going into our medical problems and where I actually use OMM. And the first one being migraines. Migraines is one of the things I see more than any other medical problem, especially on the psychiatric floor. You'll find when patients come in manic or they're very depressed, they all have headaches. A lot of psychotic patients have a lot of headaches and have a history of migraines. And when we start looking at our medications, you find that mental health patients in general have one of the highest risks for polypharmacy. If you come in with bipolar disorder, odds are you're going to leave on 2 medications as it is. And then all of a sudden you have a migraine problem and you're leaving on medication for migraines. Just basic criteria. This comes out of our neurology for psychiatrists, but the big thing is nausea. They have to have nausea, vomiting, or photophobia or phonophobia, a lot of light, sound sensitivity, and then a lot of, they say, unilateral or pulsating quality. So what kind of medications do we use for migraines in general? Like if you have a migraine, you have an emergency medication, what kind of medication do we use for those? I think I'm here. Triptans. And what's the mechanism of action of a triptan? What's that? I'm sorry, I can't hear. Vascular, and it through, and not just that, but through serotonin. So when I have my psychiatric patients and I'm giving them all these medications for depression, or they have bipolar disorder, what do you think is one of the last medications I want to use to treat their migraines? Because you end up with risk of serotonin syndrome. And not only that, but patients with bipolar disorder who are not stable, adding more serotonin in the system can cause mania. And when we have these patients with depression, and we're adding more serotonin in their system with medication, and then we're adding even more serotonin because they're having a migraine, you can have a lot of medication side effects. I probably treat migraines with OMM a couple times a week. When I was an outpatient provider, I actually wouldn't schedule appointments for my patients with migraines. They knew my clinic hours, and they would just come in, and I would see them between patients, because doing OMM for migraines, especially an acute attack, does not take a lot of time. And it prevented me from having them on medications they didn't need to be on. There are two basic procedures I use. I'm sure that people use a lot more. I'm just going to be full disclaimer here. As a psychiatrist, you would not believe how much you lose in OMM, and you get very proficient in what you know. So the first thing I always do is suboccipital inhibition, because even though it's a migraine, they have a lot of tension that goes along with that, and I'll see a lot of tension headache that goes along with the suboccipital inhibition. So I will do this just to loosen them up to begin with, and if I don't do this to begin with, what I do next, I can't get them to relax enough to do it. And then the second thing I do is a frontal lift. So the one thing I do when I use this to treat a migraine is, when you look at the criteria here, I can't read this on the screen, but it says you're going to feel a pulse evenly between the fingers. So when I'm doing a frontal lift on a patient with a migraine, is when you find that even pulse between your fingers on both sides bilaterally, and you get that equal pulsation on both sides, they will tell you they have this real weird feeling, but their pain is gone. And the more acute, the longer it takes me to get it, but it's a real gentle touch, and a frontal lift, you're just lifting, and basically you just want to feel that equal rhythm between both your hands equally. And when you get that, you'll find that you'll have resolution of the migraine. Make sure you get them up real slow, because they're usually a little dizzy when you do it. And takes me usually about 5 minutes. So that's why, especially as an outpatient clinic, and my patients with migraines, they were just, what my clinic hours are here. You come in and I will treat you. And they just had a little room, I'd go in and do that. I had one patient who was severely schizoaffective disorder, and she was on 6 medications when I started seeing her. When I started treating her somatic complaints, one of the biggest one being a migraine. When I left my outpatient practice to go in the hospital, I had her only on one medication, which was clozapine. And she had migraines about once a month. She'd come in. And when I passed off my clinic, it was a resident clinic, so I was able to pass her off to another osteopathic resident that I knew would do the same thing. Next thing I'd like to talk about is irritable bowel syndrome. Irritable bowel syndrome is very much, it just has this huge link with anxiety and mental illness. One of the things, the way I explain to patients is having butterflies in your stomach. How many people, when you're nervous, have that upset feeling in your stomach, right? And how often do you feel it in your stomach before it ever gets to your brain? Right? Do you notice all of a sudden your stomach just starts going, and then basically what we're finding out is our brain is in our belly, right? How many people eat because you're stressed? I will tell you right now, before I went to med school, I was all about, I gotta get healthy, I used to be much heavier than I used to be 450 pounds, I lost all this weight. I come in, I'm going, I'm not gonna gain any weight, and I wouldn't eat junk food before I came in, and it didn't take 2 months before I was back on the Cheetos again. So, the fact is that there is more serotonin receptors in your gut than anywhere in your body. When we look at serotonin receptors, there's so much of the serotonin that's in your belly, and then we're using that to also treat depression. It's only logical that you'll see all these patients with a lot of stomach pain. and a lot of diarrhea and constipation. If you look at the first side effect of almost any psychiatric medication, what do you think that is? I'm sure there's an exception out there, but for the most part, what do you think is the first side effect of every psychiatric medication? Constipation or diarrhea, and you don't know which one it's going to be. So, and a lot of that has to do with the mechanism of action with serotonin, because so many of our psychiatric medications affect serotonin. Even our atypical antipsychotics target serotonin receptors. So again, we're going through, and that deficiency in serotonin when you're depressed and you have a lot of anxiety. If you have problems with serotonin in the brain, why do you think you're not going to have problems with serotonin in the gut? It's that whole mind-body connection, structure, and function we talk about. So first-line treatment, I'm not even going to tell you it's OMT, it's fiber. What is one of the big things when we talk to our patients about is their diet. And I get a lot of jokes because one of the two first things patients get when they start coming to see me is the first one is fish oil because of the diabetes, heart problems, but also the link with fish oil and anxiety and mood. And the second is fiber, because I have yet to have a patient that comes in and tells me they have perfect bowel health. They all have issues with constipation, or they all have issues with diarrhea. And basically with Metamucil, what we're doing, or one of those bulk fiber supplements, is replacing a good diet, right? Because in all honesty, it would be a lot better if they would just eat a high fiber diet. The big thing is sometimes a lot of my patients don't drink enough water with it, which can be constipating. So this is the first thing I do. Good bowel health improves their mood all the time. It stimulates the gut, it makes it work. When we look at medical management, it skipped a slide somehow. It's missing a slide, but when we take fiber first, and they talk about antidiarrheals, but a big part of irritable bowel is focusing on foods, managing stress. You notice stress is on there, so we're managing our mood to deal with our stomach problems. Trying different therapies such as cognitive behavioral therapy, medications. Lastly, antispasmodics, which like Zolnorm here focuses on serotonin. Do I want to put this in my body if I'm treating them with antidepressants? And then we use Zoloft. A lot of my patients I treat with irritable bowel syndrome, I will go with a high dose of Zoloft or sertraline because you're targeting that serotonin as well as dealing with their comorbid anxiety. But again, I have all these fragile patients on a lot of medications. Do I really want to go with the medication route? So I do a lot of OMM on my patients for bowel issues. And there's more than you would believe. Weekly, I'm doing this in the hospital where I'm at. I'm getting to the point now I feel like I do more of this in migraines because I work in a state hospital. And so many of my medications are constipating as it is. And if you looked at the medications and the bowel regimens of my patients on a lot of our psychiatric medications, they take more medications, have regular bowel movements than they're on medicines for their moods. So the first thing I do is a sphincter release. And I remember when I was in school and we would do the sphincter releases here, I felt like I really wasn't doing anything. And I think I know the reason for that is we talk to all of us, it's very hard. I think one of the reasons we get good at OMT in our first 2 years is we're treating a lot of people that don't have big complaints. But when you start getting to patients with real problems, I will tell you, you can feel that sphincter release, and it's one of the best things. You'll just feel the gurgling, and you'll feel things start moving as you do hit those sphincters. So I always hit my kinks in the colon. And then the last thing I do is a colon lift, and I will spend a lot of time moving that gut around, just stimulating it, getting it with my hands and moving it. And I almost feel like if they aren't passing gas, you're doing something wrong. So just be prepared for that. When you start moving this gut around that doesn't move, you know, you're talking about these guts on all these medications that slow them down, whether it be even like you see a lot with Subocciptal, a lot of our second generation antipsychotics like olanzapine and Clozaril, they really slow down the gut. Some of our SSRIs can do it. If you prescribe paroxetine or Paxil, that really slows down the gut too. And so you start piling on all these medications, and something like this really leads to a lot less medications. I mean, it's almost commonplace that patients come in and they're almost put on Docusate on the spot, and you're giving PRNs of lactulose on weekends because they haven't had a bowel movement in 3 or 4 days. So this is something else I do regularly. The last thing I'd like to talk about today is chronic pain. I'm not going to talk so much about techniques I use for chronic pain because there's so many out there, and every patient is so different when I deal with this. But what I would like to do is hopefully make you all look at chronic pain differently today, and why it's important that we get ahead of chronic pain. So what kind of patients have chronic pain off the bat? What people with depression have chronic pain in general? Have many people spent any time yet in pain clinics or any addiction clinics yet? Traumatic history, like they have chronic problems. And in general, when you see patients with more pain, do you feel like you see more patients with higher pain levels on opiates versus other medications? I feel like we've seen more chronic pain since I've just noticed a bigger influx of it since I was paramedic in the 90s, back when pain became the fifth vital sign. And when we look at the link between pain and mental health, and we look at our monoamine hypothesis, the one I'd like to focus on here is norepinephrine. When we look at chronic pain regimens, the medications we use for that, one of the big ones is SNRIs. And we use norepinephrine to help combat chronic pain. But why do you think that norepinephrine is so involved with chronic pain? And why do you think there's mood disorders with that? Does anyone know where norepinephrine and epinephrine lie when it comes to chronic pain or pain in general? All right, we're going to go back in basic sympathetic, parasympathetic lecture, all right? A bear comes in the room and he starts attacking you. And your sympathetic nervous system goes into overdrive. And he's clawing at you, you're trying to get away. How much pain are you feeling? Why? Because your adrenaline is pumping. Norepinephrine and adrenaline have pain-relieving qualities, cover up pain. It's one of the major neurotransmitters in the CNS. It enhances your attention, it enhances your memory. So on top of that, when you have chronic pain, what do you think starts getting depleted? A lot of your norepinephrine stores, and therefore having a lot of mood problems. When we look at the leading causes of disability compared to 1961 versus 2011, you'll see the number one is back injury and pain, and the number two is mental health problems. So chronic pain management is extremely important. A lot of times I feel like a lot of our patients come in with pain, at least these are experiences I've had with a lot of my patients, and most of them do have addiction issues. They come in and they're like, I hurt. And they're like, all right, so you're looking for a pain med. Well, what can you do to help me outside of that? And they don't really like their answers because a lot of people forget that it takes a long time to feel that bad, and it takes a long time to get better. And patients who have chronic pain have a lot of issues with, they don't feel like they're being believed is a big thing. They hurt, they can't do what they used to do. Their relationships are affected. They're not able to have sexual relations with their partners anymore. Why can't anyone help them? Why can't I work anymore? Why can't I do things with my children I used to do? And all that leads in on top of it to a lot of fear and depression, anxiety. And so take your life right now in med school, and right now it's stressful, and then all of a sudden something happens and you have all this pain, you can't focus on your work, and your whole life changes. How would that make you feel? So even though I'm sitting here telling you that they have these pain issues, we need to treat it, it also doesn't mean that I'm telling you to prescribe opiates. And what I want to do right now is talk about why opiates are bad and kind of why they have all these mood problems. Because I'll tell you right now, half of my admissions in the psychiatric hospital are patients attempting suicide and suicidal thoughts based on withdrawal and drug use. And as primary care providers, we are at the forefront of that. You guys are going to see that every day. So right off the bat, why would you say we shouldn't prescribe opiate medication? Wow, that is a really good answer, and I was hoping you were going to fall into the trap of the answer most people give me. But yes, that's very close. That's kind of where I'm getting at. How many times do you hear we shouldn't prescribe opiates because they're addictive? Anyone really not hear that? I can't prescribe you that, it's addictive. But you know, if a medication worked and it was addictive and it gave your whole life back, wouldn't we prescribe it? I mean, if I can give you this pill and you can function normally, I mean, why would we? So what we're going to talk about real quick is why opiates are bad and why it does what she's saying real quick, and then how that affects mood. So if we have a nerve cell, and for the record, when we talk about this right now, this is how I explain things to patients, and I'm trying to give this information across in a way that you're going to be able to relate to people, because when you start getting patients in front of you that don't understand, education's the first thing we do. So say we have nerve receptors on the cell and we have pain. The pain is going to hit those receptors, and that signal goes to the brain. So when we give an opiate, what does it do to these pain receptors? Give an opiate. What's the opiate doing to stop the pain from getting to the brain? Blocks it. What have we done to fix the pain? Nothing. There's nothing that we've done to fix the pain. So the body's a unit and it wants to fix itself. What is the body going to do to get that pain to the brain? It's going to make more receptors. We're going to have upregulation of receptors. So what do we have to do to the opiate medication? Have to increase it. So we increase the medication and we cover more receptors. What have we done to fix the pain again? Nothing. So what does the body do from here? Makes more receptors. So what is the term for this when the therapeutic dose of a medication no longer has the same therapeutic effect? Tolerance. So all of a sudden now you have this patient on all these opiate medications, the opiates stop working because at some point the opiates stop working. And they take extra medication, or they go out and buy extra medication because they don't have enough to cover up their pain. And then they come into the doctor's office and they go, I failed my pill count today. And, or I need more medication. What happens then to their opiate medication when that happens? What do the doctors do? They cut it off. So these patients with this upregulation of receptors have pain that is 10 times worse than that of other patients. So I'm not saying we give opiate medications, but what I'm saying is that we are in a unique ability to treat these patients. What I did is I ran a dual diagnosis clinic where I treated addictions and mood disorder. And I would have to spend the last hour of my clinic every single day doing OMM on my patients for their chronic pain issues. And what we should be doing is treating these patients, because good chronic pain care comes from an overall treatment of not only their mood, because let me tell you, find me a person with pain issues that doesn't have depression or anxiety, and that's a rarity. I'm not saying they aren't out there, but it is rare. And when you look at it, it makes sense, right? They're not working. They have anxiety about providing for their family. Their relationships are bad. Their financial stressors are bad. And we as physicians, when we come in and we treat these patients and they come in with these chronic pain problems, we should be educating them. We should be teaching them why the opiate medications that weren't working before aren't working now, and why we need to work for other things. I think a lot of times the things I see is that we don't spend enough time explaining to our patients why they have the problems that they have. And if we spent more time, I feel, teaching people why you have pain or why you have depression or bipolar disorder, and we spent time explaining why they have it and understanding what it is, they're going to be a lot more invested in treatment, and they're going to hear you about your treatment and what you're going to give them. So education is the first line of treatment, I feel like, and then the second line is equal physical therapy, OMT, and NSAIDs and Tylenol. So one of the things, when I spent a lot of time in a chronic pain clinic because I felt like I had to learn how to treat chronic pain better because of the fact that I dealt with so many people with addiction issues. And I throw Tylenol up there and people make fun of it, but Tylenol is actually one of our better pain relievers we have. Does anyone know what the indication for Tylenol is? Like what kind of pain? It's mild to moderate pain. When you have pain, when do you choose to take a pain med? Usually when it's bad. So a lot of times the Tylenol won't work because they wait too long to take it. Also on top of that, like one of the best questions you can ask a patient is why is there Tylenol in like a Percocet or a Lortab? And a lot of people will tell you, well, because it limits, this way you can't take too many opiate medications. But the thing is when Tylenol is good for mild to moderate pain and you give the opiate part, it's supposed to knock down the pain enough that you can take Tylenol. And I tried this out. I had my wisdom teeth taken out about 3 years ago, and the doctor, the first thing he did was send me out the door with some Percocets, and I took one, and then I scheduled my Tylenol every 6 hours, 650 milligrams every 6 hours. And I'm not telling you I didn't have pain, but I'm telling you I didn't need any other medication other than that. In a few days, I was good. Patients, the first thing we should be doing is getting them into physical therapy and OMT. And you know, a lot of patients I hear, they always tell me physical therapy doesn't work. And I go, well, that's because you're on these pain meds. It takes like 6 months for a downregulation of those receptors. And you got to prep patients for this. You're going to be hurting for a long time, but it's going to get better. And pain is a part of life. They also don't like hearing that, but you know, we have pain for a reason. If it wasn't for pain, I would not remember where to walk at night to bed because I would continually stub my toe on the way to bed. And you know, you aren't going to burn your finger on a hot stove. You're going to learn that lesson real quick as well. So it's about realistic expectations. So we spend a lot of time educating, and also behavioral therapy. We do a lot of therapy with these patients. One of the great things about being in the clinics is I started out in addictions in the VA, and if a patient had pain management, the first thing they did is they were enrolled in CBT. So we had chiropractic services, we had pain management docs, and then we had CBT. And people who had that chronic pain, they were all put through all three, and they were given all services, and they worked really well. Then much farther down the list is drug therapy. And I think you see a lot of times we hop too fast to that. In general, I find that patients with mood problems and they don't have bipolar disorder, the SNRIs do work reasonably well. Basically duloxetine, its trade name is Cymbalta. The one I tend to use more though is venlafaxine, which is known as Effexor. And the reason why I tend to use that more is it has a lot more serotonin in it. When I'm treating a mood problem and pain, I can get Effexor up to a high enough dose to help treat a lot of their mood problems. There's also a lot of PTSD that goes along in chronic pain for whatever reason. So higher doses of the Effexor, where duloxetine, while you can go higher than what it says, there isn't a lot of good evidence at higher doses of duloxetine as there is Effexor. So the big thing to take away here is just when you have these patients with chronic pain, just remember that they are on a different level of pain than you can imagine a lot of the time. When we think we have pain, their pain is as bad as they say, and I just can't encourage people enough to use OMM. Gentle at first, whether it's fibromyalgia or an injury or addiction, whatever it is. I find that a lot of my medications stay lower because of it. So I'd go ahead and like to answer any questions, throw in this last thing out here, you know, knowing is half the battle. G.I. Joe, half red lasers, half blue lasers.
Todd,
I'm showing my age.
we'll get questions. I just wanted to tell you that my brother-in-law in Phoenix, Arizona, MD psychiatrist, learned about osteopathic medicine here when he came for track meets. I kept my license in Arizona for years. He used to store up the patients with somatic problems. In the first 2 years, I was treating them on the floor because they don't have a table or a couch or whatever that you think a psychiatrist would have. But he stored up his patients so I could do OMT on them when I went to out west a couple of times a year.
Yeah.
Questions for Dr. Jamrose?
Yeah. You know,
Sure.
when I started working at the state hospital, the exam room was not OMM friendly. I walked the tables up in the corner of the room and bent up. I'm like, oh, next thing I know, I'm moving this out. So they had to start changing the exam rooms downstairs because they got tired of moving the table.
Yeah.
Do you ever have problems prescribing alternative treatments for patients outside of medicine, such as saying, go get some massage or go get some OMT, but then their insurance doesn't want to pay for it?
So I don't bill for OMM in my community health, and I check the button at the hospital when I do. Like I have a little page and I check it. So I don't really know if it's getting billed or not. There are a lot of problems with billing in general in mental health. So in the clinic where I worked in outpatient, I saw the dual diagnosis patients. Part of the reason I saw dual diagnosis patients is because I was able to have a program that paid for everything they needed. So when I had that dual diagnosis program, you know, I'd see them for their addiction during their appointment, but I'd always pull them out of a group in therapy. So all my patients were in groups in therapy every evening, and I'd pull patients out of there. So then I would treat them when I would need to and just write an addendum on a note. And I just didn't look at the monetary side of it. I was paid an hourly wage, and I didn't really care about the billing side of it. Maybe I should have, but really I was just thinking about treating the patients and not that private side.
You said you worked with veterans, yeah?
What's that?
You worked with veterans?
I did that
PTSD?
for 4 years at the VA.
Okay, I'm a veteran myself, so I was wondering if you have seen a correlation between chronic pain, PTSD, and the suicide rate.
You know, I'm seeing a lot of times I feel like it's the opiate use itself leads to so many suicide attempts and so many suicides. And then you just complicate that with PTSD. And a lot of times, a lot of people don't understand. I'm not a veteran, but that's where I did my residency, and that's where I spent all my time was with these patients. And they all come back, and they were just prescribed things on tour that were they were just setting them up for addiction when they left. I mean, oh, okay, your shoulder hurts. Here's a bunch of opiates. Oh, you can't sleep. Here's a lot of Ambien and benzos. And I mean, so then all of a sudden these veterans come back and they have these unrealistic expectations for treatment because we know what we do that helps people, and we aren't going to throw an opiate at them, or we're not going to throw a benzo at them. And I can't tell you how many vets were upset with me when they first saw me. A lot of my relationships on initial encounters with veterans were a little rocky at first, and even with patients now are a little rocky because I don't prescribe many benzodiazepines at all, very rarely. And I'll tell you that I do not even have Xanax. I forget how to spell it. I don't use it. You know, but then when they come back and they realize they don't have a choice but deal with you, and they come back and I'm just very blunt, and I don't dance around things. And, you know, I end up with really good success stories from that, because when a patient gets to the point they know, here are your options, you feel bad, you need to get better, and they start doing well. But I think I got a little bit away from your question, but I feel like I just see a huge suicide rates with opiates in general. I was practicing in Chillicothe, Ohio, where the state in the news for the missing women and the opiate overdoses everywhere. And that was actually, sad to say, part of the reason I had to get out of Chillicothe is I got tired of reading the paper and seeing my patients die. And then on top of that, you add to the PTSD, and patients come in and they have this very high anxiety, and we aren't treating with benzos. We are using other things like prazosin, where we have really good therapies, but none of them are just this immediate fix. And when you live that torture and that upset, you want something right now. And I think it's all of it together, and then a lot of times you have that combination that makes it even worse.
One last question. Anyone? Yes.
Were you able to treat any patients in an acute setting where you found OMT to be beneficial? Because we've kind of talked about sort of the longer term patients that you have.
Right.
But in acute setting, it's a little bit different.
In the acute setting, I do not do a lot of OMM other than a lot of the side treatment. So I'm in a unique position, is when I see a patient when they're acutely ill, a lot of times it isn't something as, I shouldn't say simple, but it's like they have major depression or they have anxiety. I work in a state hospital, and there's a 45,000 physician deficit in psychiatry. So by the time a patient gets to me, they are so ill and they have so much, their problems are usually a lot bigger than that me giving them OMM, it just isn't appropriate because they're psychotic and they're hearing voices or they're delusional. And you know, there's a lot to having to get that trust and that therapeutic relationship before a patient like that will let you put your hands on them to begin with. So I'd say that if I had an acutely ill patient, and I have had a couple, that it was just first time hospitalization, they were just bipolar, I'm not bipolar, but depression, and or just anxiety, and I was able to help treat that. Migraines is usually the big one. If they have an acute illness, I'll go with the migraine first.
And Dr. Jamrose, would you stick around a little bit so people want to visit with you
Sure will.
and have a few other personal questions? Thank you all very much for coming, and thank you, Dr. Jamrose.
Thank you.